have a pretty ambitious agenda here to kind of hit, I think, some of the highlights in clinical bone in the last year. And I really have no disclosures. And I'm going to break it up into 4 buckets, really. I'm going to focus on a couple of hot areas in osteoporosis. I'll hit a few, I think, really interesting things in vitamin D, which is another hot area. I'll cover some stuff on hyper and hypoparathyroidism, and then I'll have one study I want to highlight in rare bone disease. So the first thing I want to cover really is this concept of therapeutic transitions, which I think is one of the more challenging things that we're faced with, especially if you're a specialist. And I'm going to highlight 4 particular trials that I thought were quite interesting. And the first one is a study from Kendler that was published in JCEM in the last year, where they looked at 126 patients who had 1 year of DMAB, denosumab, and then after that they were transitioned over, the majority of them, to alendronate. And as you can see, that transition to oral bisphosphonate therapy maintained bone density after a year of DMAB. And this is consistent with a study from Fremantle that was published a few years prior to this. So keep that in mind as we look at the next study, which was a study from Saling and colleagues. And so this is published in the JBMR in the last year. And what they did is essentially take a group of patients who were on an average of about 4.5 years of denosumab, and then they transitioned them with 3 different strategies to zoledronic acid. And one strategy was just to give it 6 months from the last DMAB injection. And as you can see, they lost bone when they did that. In the same way, they had another strategy of just empirically giving it 9 months, thinking that the skeleton would start to awaken and maybe get better bisphosphonate uptake. But that really didn't work either, as it turns out, on this follow-up of 1.5 years in the published data. And then the third arm was the one where they actually looked at bone turnover markers, beta CTX, and drop in bone density to determine when to give the next dose in the in this kind of observational cohort. And so none of these strategies really were able to maintain the bone density. And they just had the 2-year data presented to ASBMR, and that again showed that ZA didn't prevent bone loss with that transition from DMAB. And what they showed as well was that longer use of DMAB was associated with greater bone loss when you transition to ZA. And finally, the other interesting point I thought was that in the 6-month strategy, at least they found that you didn't give as big of a rapid bone loss and as big of an increase in beta CTX. So from what I can tell, at least that 6-month strategy may be the most reasonable. But I'll also point out that about half of those patients received a subsequent dose of ZA when their bone turnover markers and bone density changed in an unfavorable way. Now, there's one other study on this transition from DMAB to ZA from the Makris group, where they had patients on 2 years of DMAB, and then they were transitioned to Zol, just 1 dose. This was just a open label single dose of ZA after an average of 2.4 years of DMAB. And they actually showed maintenance of bone density, at least in this small open label trial. Now, the final transition study that I thought was interesting was this Japanese data. And so, and I know somebody's talking about Romo later this evening, but what they did in this is they looked at essentially taking patients who were either drug naive going to Romo in the blue, dark blue. Clearly, drug naive patients respond the best to Romo, and that's an important message. They also looked very interestingly at about 10 months of teriparatide followed by Romo, and surprisingly, they actually got a very nice increase in bone density with that transition. When you transition from bisphosphonates or from Romo to bisphosphonate, when you go from bisphosphonates to Romo, that works as well. But again, and this is consistent with data published by Kendler in 2019, an important point is when they looked at patients going from DMAB to Romo, you don't get much of a benefit as far as bone density at the spine, at the hip, either at the femur neck or the total hip. And so I really think the messages from the transition are that ZA appears to work if it's given at 6 months, or appears to work best if you just give it empirically at 6 months after the last DMAB injection, from what I can tell. ZA after DMAB may maintain bone density with shorter term exposure, like 2 years, but with longer term exposure, it seems like it's just isn't as beneficial as maintaining bone density. On the other hand, alendronate after short-term DMAB anyway does show consistent benefit in maintaining bone density. And personally, I know there's debate about this even within this group, but for me, I think that's the best strategy. If there's a reason, you can use an oral bisphosphonate, just because the skeleton is so quiescent, and as it reawakens, this periodic exposure to alendronate seems to make sense that it might be a better choice. And then I'll just say that Romo after DMAB is a bad strategy. And in fact, kind of my take-home messages, especially more for primary care, where this can get a little bit, it's not always clear, but drug holidays really, as you all know, only apply to bisphosphonates. And I just want to point out that you don't want to switch from DMAB to PTH-based therapies based on the data switch study from the Harvard group. And so, and the other thing is I would not recommend, based on this data, that we transition from DMAB to Romo. So those are kind of the take-home points with transition to therapies. Now, going on to therapeutic side effects, I think this was the other really interesting area in bone in the last year. And probably the most important study was this data from Dennis Black at UCSF, published in the New England Journal this past year. And I'm guessing that most of you have seen this already. But what they did is they looked at the Kaiser Permanente database of about 2,000 women on bisphosphonates. There were 277 AFFs, atypical femur fractures, and they looked at risk factors, and they're consistent with what we thought was true beforehand for the most part. Longer duration of bisphosphonate use is associated with increased risk. Asians are particularly prone to AFF. So these are a population when you're trying to decide on drug holiday versus continued therapy. These are maybe you're going to have a lower threshold to go on that drug holiday. Shorter height, greater weight, although there's small relative risk. And then glucocorticoid use, which is somewhat of a problem, I think, because obviously ongoing glucocorticoids but have a real significant increase in fracture risk. So we need to keep that in mind. What was really surprising to me, and also in another study that was just published, or that was just shown at the ASBMR this last year, a Danish cohort showed the same kind of findings. Once you stop bisphosphonates, you see a very rapid reduction in the risk of AFFs within that first year, essentially. And so I don't know if I quite understand why that would happen, but I find that pretty interesting, actually. And the take-home message for our patients are that even though AFF risk is higher in Asians, if you have a high fracture risk, the number of clinical fractures you prevent, obviously, in all subgroups of women, no matter what your ethnicity is, will outweigh the small risk of AFFs. Now, another important study that came out in the JBMR within the last year was teriparatide and the risk of osteosarcomas. So as you all know, we often will tell our patients, we have been telling our patients that there's a black box warning about osteosarcoma risk based on rat pre-clinical trial rat data with teriparatide. And so because of that, the FDA mandated that they do a surveillance study, which was completed just in the last year or so, and the data was published in the JBMR. And what they basically showed is that the incidence of osteosarcoma with teriparatide is no different from what's expected. And essentially, because of that, the black box warning now has been eliminated from teriparatide for osteosarcoma risk. So that's reassuring data. And then finally, as far as side effects, I just wanted to highlight this abstract or this oral presentation, ASBMR. And what they did is they looked at AFib within the year after treatment with either zoledronic acid or denosumab. And what they found was this signal again, and this has been seen before, that atrial fibrillation diagnosis increases within the first year after ZA more so than in compared to DMAB. AF hospitalization was slightly increased. And I just want to point out too, that was kind of interesting that fractures and malignancy were reduced more so with DMAB compared. It were higher with ZA than with DMAB. So that's just kind of an off finding. But so to summarize therapeutic side effects: duration of bisphosphonate use, Asian ethnicity, shorter height, higher weight, and glucocorticoid use more than 1 year are AFF risk factors. The risk for AFF goes down rapidly after bisphosphonate discontinuation. Osteosarcoma risk is no different from expected with teriparatide. And ZA is associated with increased risk of atrial fibrillation compared to DMAB within the first year after treatment, but the absolute risk is actually relatively low. So moving on to vitamin D, there's just a lot of stuff emerging about just vitamin D metabolism. And I want to focus, just for the purposes of the next study, on the CYP2R1, which is the 25-hydroxylase gene. And there was this very interesting study from the Rosen and Michael Levine group in Philadelphia, published in the JCEM, where they did a series of studies looking at different alleles for the 25-hydroxylase gene. And they did some in silico modeling to look at importance, as well as in vitro 25-hydroxylase activity. And they found those alleles that were associated with reduction in 25-hydroxylase activity. And then what they did is looked at population gene databases. And what they found was that essentially the closer you live to the equator, the less the less 25-hydroxylase activity that you found, or there are more alleles with decreased 25-hydroxylase activity. And you can see that they were more common in African Americans than Caucasians, for example. They had a similar finding looking at the GC protein, which is a regulator of the vitamin D binding protein. So there was more non-functioning alleles in vitamin D binding protein with closer proximity to the equator. And so this is all consistent with a positive selection related to differential exposure to UVB. Now, many of you have already seen this, so I'm not going to spend too much time on this, but this was another, I thought, very interesting study with comparing 3 different doses of vitamin D in a cohort of women and men from Calgary, where they looked at 400 in the green, 4,000 or 10,000 IUs of vitamin D in a prospective randomized 3-year trial, and they used volumetric bone mineral density to look at what happens at the bone level. And I think many of you know that higher dose of vitamin D was associated with a decrease in bone density. And you can see with each incremental increase, there was a decrease in bone density. So that's old news. But what came out, the new news that's come out of this actually is this. What they found in an oral presentation at ASBMR this year was that loss was seen in women, but not in men. And in fact, when you look at bone turnover markers, they had a trend towards increased bone turnover markers in women. And the other thing they found was, and this was published in the JCEM, was that although there's no difference in median calcium or 24-hour urine calcium, there is an increased risk with increasing doses of vitamin D for patients who developed hypercalcemia that was actually mitigated by reducing calcium intake, and also an increased risk of developing hypercalciuria. And then finally, in the vitamin D area, there's a lot of data that was published on the VITAL trial, which many of you, I'm sure all of you are aware, was a huge study on giving vitamin D3 2,000 international units to a community-based cohort of individuals who are healthy and vitamin D sufficient for the most part. And they basically found no benefit from a DEXA bone density standpoint or a volumetric bone density standpoint with PQCT. They also found no reduction in falls based on questionnaires over the 5.3 years of the study. And they also found no difference in depression with vitamin D. I really don't find these very surprising, and I'm sure most of you don't either. But again, just really for healthy, sufficient individuals, there's probably limited benefit suggested here. So summarizing vitamin D, there are genetic variations in vitamin D metabolism consistent with selection related to UVB exposure. High dose of vitamin D is associated with a reduction in volumetric BMD and an increased frequency of hypercalcemia and hypercalciuria, the latter of which, it was actually the hypercalciuria that was mitigated by reducing calcium intake. And vitamin D in healthy vitamin D sufficient adults really hasn't shown short-term benefits in bone density or prevention of falls and depression. But I think it's really important to point out that really doesn't address what we're interested in, which is the 1/5 of adults who have, vitamin D levels that are below 20 nanograms per ml. And so that's really an important take-home point. Okay. So as we rapidly move through the year in bone, I want to now cover a couple of studies in hyperparathyroidism. And the first one is data from a osteoporosis clinic, essentially in England. And amazingly, this got published in the JCM. They had 11 patients in this study with normal calcemic hyperparathyroidism. And they basically concluded that most of these patients have intermittent hypercalcemia, and it's a mild form of primary hyperparathyroidism. And PTH fluctuates as well. So I think any of us who see normal calcemic hyperparathyroidism, and unfortunately I see more than I would like, we know that this is true. Now, more interestingly, I think, was this data from Italy, from the Palmero group, where they had a fairly decent sized cohort of patients with normal calcemic primary hyperparathyroidism. And what they did is they compared these patients to thyroid controls as well as patients with high calcium and high PTH, or a traditional primary hyperparathyroidism group. But what they found was when they looked at the thyroid control group, there was really no difference in bone turnover markers, morphometric vertebral fractures. But in the primary hyperparathyroid group, again, there were about 25% that had vertebral fractures. So that's important to recognize. They didn't see any increased risk in clinical fractures, decrement in bone mineral density, and no difference in 24-hour urine calcium. The only thing that was different was that they had a higher PTH and they had a slightly lower phosphorus. And I have to throw in one bone from one of our studies, which I thought was interesting. We did this with our surgeons, where there's very little known about what happens to patients with hypercalciuria after parathyroidectomy. And what we demonstrated in this cohort of patients that had surgery was we looked at pre and post-op measurements in those who had 24-hour urine calciums. And clearly, 24-hour urine calcium drops when you have a successful parathyroidectomy. 93% have a greater than 20% reduction in their 24-hour urine calcium. But most importantly, in the hypercalciuric subset with 24-hour urine calciums above 400 milligrams, 80% of them had a normalization of their 24-hour urine calcium. And so it just kind of confirmed that hypercalciuria seems to be something where you can get definite benefit with successful parathyroidectomy. The other thing that's kind of interesting, and I'm getting more interested in, is what happens after parathyroidectomy. And this was data from the University of Michigan, where they looked at those who had biochemical measures shortly after surgery and then 6 months or longer after surgery. And it was a pretty large cohort over a pretty long period of time. It was actually 18-year period. And this is depressing data for me, because I see some of these patients. But what they found was that only 75% of patients actually have normalization of both PTH and calcium. About 11% of patients actually have a normal calcium but high PTH. And I'll just say there's been recent data from North Carolina suggesting 30% of patients have a high PTH after successful parathyroidectomy. There's another 11% who have high calcium with a normal PTH, and then about 3% that are non-respond or that have a persistent disease. The point here, though, is that 25% of patients after parathyroidectomy have some abnormality in their calcium biomarkers. And I thought it was very interesting. I'm going to walk you through the two important points here, so don't worry too much about details. But the key points here is that in those patients who have increased PTH and normal serum calcium, their risk of confirmed hypercalcemia is about 27%. And it's more than those patients with high calcium and normal PTH. And and overall, about 10% of their cohort actually had recurrence of disease. And we're actually looking at our 45-year data from Olmsted County, and I think this number is going to be about right, about a 10% risk of recurrence of primary hyperparathyroidism. So the point here is that if you have a high PTH after parathyroidectomy with a normal calcium, there does appear to be a significant risk of recurrent disease in the future. So to summarize, hyperparathyroidism, normal calcemic primary hyperparathyroidism is a mild form of primary hyperparathyroidism and may have less associated sequelae versus classical disease. 24-hour urine calcium improves significantly after successful parathyroidectomy. Elevated PTH and/or calcium within 6 months of the parathyroidectomy are common, and in fact, those with high PTH but normal calcium seem to have a higher risk of recurrence. And then finally, about 10% of patients will have recurrence of their primary hyperparathyroidism, so long-term follow-up is recommended. Now, in the area of hypoparathyroidism, I just want to highlight this data that is consistent with other randomized and then open label study after the randomization period from pivotal trials. But this is basically looking at eGFR over time in patients in a historical cohort compared to patients from 4 open label trials for recombinant PTH 184. And it's pretty clear to me with all of these studies that one of the benefits of PTH replacement therapy is preservation of renal function. And so I think there's just more and more data emerging that PTH replacement therapy is good for the kidneys compared to traditional therapies. And I just want to highlight as well this TransCon PTH, which is a PTH now in phase 3, going into phase 3 trials and soon. But the point here is this has our PTH now, PTH 184 and that para has a half-life of like 3 hours. This PTH has a half-life of about 60 hours. And so you can imagine if you have a longer duration of PTH, it could have better benefit as far as improving calcium stability. If you miss a dose of or miss an injection, you're going to have less risk of hypocalcemia. You're going to have more effect on the distal renal tubule of reabsorption of calcium and reducing hypercalciuria. And you're going to have an increase in sodium phosphate transporter activity and increased renal phosphate excretion. And indeed, when they presented their oral data at the ASBMR from the 4-week data in their phase 2 trials, it basically showed that 80% of their patients were off active vitamin D within a month after getting on TransCon PTH and were on lower doses of calcium. Half of them by a month were actually off all active D and calcium. So more to come on that, but I think that's one we want to keep our eyes on. So PTH 1 to 84 in chronic hypopara has consistent benefit in consistent renal benefit that's been demonstrated compared to traditional replacement therapy. And TransCon PTH, I think, is a promising replacement therapy. And last but not least, I just wanted to highlight this data again at the ASBMR annual meeting on burosumab. And this is data, as you know, burosumab are FGF23 antibodies approved for use in XLH, but they're all also FDA approved for tumor-induced osteomalacia. And the data from their clinical trials in 14 patients was presented and basically shows that burosumab works in TIO. Obviously, the treatment for TIO is surgery, but oftentimes we can't find the small tumors. In those patients, there appears, these are certainly candidates where this may be a viable therapy. So with that, I will stop and open it up to questions. Thank you.
Okay, thank you, Dr. Wermers. Go ahead and send me questions via chat. We've got a few minutes for questions. I do have one for you to start. I'm very concerned that both the alendronate after DMAB studies were after only 1 year of DMAB. I'm worried about using alendronate after long courses of DMAB.
Yeah, I would say we certainly don't have longer term data, and I know there's a variance on opinion here. I've heard some of my colleagues say they have the same kind of concerns. I'll just say that the data in 2 trials is consistent with shorter term use, but we need longer term data. There are some theoretical reasons why oral therapy makes sense to me. If you think about it, a third of bone biopsies in the denosumab pivotal trials showed no label uptake on bone biopsies. So skeletal activity is very low. And if you give a big bolus of IV bisphosphonate, it makes sense that there may be limited skeletal uptake. As opposed to bisphosphonate that you're taking every week, and as you get skeletal activity increasing, you're going to see some uptake of bisphosphonate theoretically. So I share your concern. I don't have the data to answer your question, but I think more data, and I think more data is needed. But ZA, what I could say is at least with longer term treatment, doesn't appear to be completely beneficial in maintaining bone density.
Okay. The next person apologizes for missing the first couple of slides, but asks if zoledronate timing after Prolia for 6 months, after last injection, or 9 months, and why?
Yeah, I mean, their data, none of them completely held after 4.5 years of DMAB, but what they noted was that you get this big rebound in bone turnover markers that can occur when you delay therapy. You can also get a rapid decrease in bone density that occurs shortly after after that 6-month point. By giving ZA at 6 months, they didn't see as big of a rebound in beta cross-lapse bone resorption markers or in decrements, and as big of decrements early on in bone density. So they felt, at least in their data, that it suggested that 6 months might be preferable than other strategies of waiting and following turnover markers to decide on therapy.
Okay, what is the recurrence rate for primary hyperparathyroidism if you exclude patients with a family history of hyperparathyroidism or known hyperparathyroidism syndrome?
Well, that data, as I recall, that data from Michigan was they excluded, familial parathyroid causes, so MEN1. So I think the recurrence rate's about 10% from what I can see
Okay.
long term. Yeah.
How often do you think we should be monitoring for primary hyperparathyroidism recurrence in those with and without high parathyroid levels after surgery?
Yeah. So, well, I think some people would say never check a PTH after surgery unless you want to suffer. So, whether to check a PTH after surgery or not, I think it's not. I showed you some data that says maybe we should be. To be honest, I use a calcium. I check calcium within that first 6 months, and then I recommend if that's normal to do one annually, just because does appear to be about a 1 in 10 chance of recurrence. Now, I may change my mind on that. I may just based on some of this emerging data, maybe we should be checking PTHs. But the problem is then we get stuck into this anxious patient, and so I don't know the right answer for sure on whether or not we should check PTH. I'd be curious maybe what some other of my colleagues think, but if they check it. But once a year after you document normal calcium within the first 6 months, the short answer.
Here's a question to whomever would like to answer. Does anyone know if the removal of the black box warning for teriparatide has changed the radiation therapy contraindication?
I don't. I guess I'll take that since I brought that study up. You know, I don't think it takes away that concern, and I still think if I remember, the label still includes radiation as like a precaution in there.
It does.
So I just recently looked at this, and I think that's what I recalled. But I think with this information, what it tells me is that if you have a patient where you can have a very compelling reason to use a PTH analog, even if they've had a history of radiation, maybe more remotely for breast cancer or whatever, I would talk about the risks and benefits, and I would consider, in that patient where I really thought they would benefit, that I might use it. But I talk with the patient about it. And a classic example would be glucocorticoids, where I think these drugs have a real big role for severe glucocorticoid-induced osteoporosis, where the primary defect is the osteoblast. These drugs work really well. But yeah, I don't know, Elaine, do you have any comments on that?
Only that I had the same question, and I think the kind of clinical judgments you're saying make sense and are sort of probably how I will kind of alter my practice going forward based on that. But I did look specifically to see if that change, that was still, it is still in the labeling as a at least precaution, if not contraindication.
Excellent. Thank you very much. Those are our questions.